Hello, Marissa.
Hello, hello. How are you today?
I'm good. So, for those who are just now joining us, we are doing kind of a two-part little series on the cheerleader, the gymnast, and the dancer. And part one, we focused in a little bit more on the spine. And you are here for part two, which is hypermobility. And so I am Melinda Paulsell. I'm a physical therapist. I've been a physical therapist for about 20 years now. I am the founder of Stop the Progression and CheerX and a spine and performance specialist. And more than that, a Schroff trained spine and performance specialist. And so joining us today is Marissa Muccio, and she is a physical therapist and has been for quite some time now and has been
Coming up there,
specializing in the
30 years.
treatment. Yes, and has been specializing in the treatment of scoliosis. And Marissa's background is pretty extensive in scoliosis. So she is certified BSPTS. She is ISICO master's course. She is a PSSE Schroff instructor, and she is an early member of the Scoliosis Research Society and committee member of the Comprehensive Care Committee, SOSORT, and APTA. She's also a clinical instructor and researcher and co-owner of the Scoliosis Specialty Centers, which has locations in both New Jersey and in South Carolina. So Marissa, thank you so much for joining us today.
My pleasure. This is one of my passionate subjects.
Yeah, so when we were chatting previously, we were really talking a lot scoliosis, but hypermobility just kept popping into the conversation over and over and over. And at the time, you did not know that I was doing work with cheerleaders and gymnasts and dancers. And like my head, when you were talking about everything, like my head was just jumping up and down as much as it could. It was just nodding because I was like, yes. Yes. And so, we really kind of hope to do a webinar with both spine-based and hypermobility, but we realized there was really a lot of information out there for the hypermobility. So we kind of wanted to split it up into two separate parts so that we could really kind of tackle this and make it make sense and make it understandable to people who might have a general idea about hypermobility, but may not really know everything that it entails.
Right.
So let me get my ducks in a row here.
A lot of information is changing rapidly these last 10 years in terms of research and regarding hypermobility. Ever since 2017, when the international paper was set forth with the categories of different types of connective tissue. And it's changed dramatically. And it becomes really more important because of the genetics, that there's an overlap between scoliosis, idiopathic scoliosis that is common within teenagers, and joint hypermobility. And we suspect that is probably that shared overlap is part of why we see more dancers, cheerleaders, and gymnasts with scoliosis. Again, we had talked previously about the fact that it's not the sports there that causes it. It's that they have this, for some, shared genetics that makes them more successful. They are already looser in their capsules, in their connective tissues, and in their joints. And so we see a higher prevalence of scoliosis within these sport populations. And within that, we already know that almost somewhere between 30 to 50%, it varies from studies to study, of kids with scoliosis will also have hypermobility. In our own clinic, when we take a look at our data and so forth, we're at like 49% of our patients with idiopathic scoliosis for adolescents will have joint hypermobility.
I believe it.
Yep. And so it's key for your viewers to understand this is not the same thing as our kiddos who are really well stretched. And
let's talk about that.
Yes.
Let's hit on that. So can you just talk about what general hypermobility is and how that differs from flexibility or even trained hypermobility?
Right. So you can train a muscle as any good athlete does, to be longer and to stretch across wider ranges of motions for any sport that you're looking to optimize that particular muscle group's performance. But especially cheer, dancing, and gymnasts, obviously you want the most power and the most range so that you can get those dramatic motor performances and positions. And with that comes trained flexibility, right? And that's the extensibility of that particular muscle, the ligaments, the tendons, and across the joints, so to speak. However, joint hypermobility is when a joint is you're kind of born with it to a certain extent. You've got that basic genetics where the connective tissue is looser in your body than the average person and the average child or teen. And so the joint capsules themselves are looser. These are the non-elastic structures, right? When you think about muscles, you think about them being elastic, they can go back and forth, and you can make that elastic elongation easier with stretching and so forth. And you can change the length of things like ligaments and some tendons and things. But really, the joint capsule itself is a set kind of range of typical and what we consider to be, healthy and biomechanically optimal. Now, I am not joint hypermobile, but as a ballet dancer, I could put my foot straight up because I worked really hard to get that. Whereas some of my friends who were joint hypermobile didn't have to stretch at all because that leg just went up and happy as can be. Right? So again, difference. So I might not be able to demonstrate some of the tests, but there's an actual screening for joint hypermobility. It's called the Beighton Modified Score, Beighton, Beighton. And it consists of testing 9 different joints. We test thumbs to the forearms, because if it touches, you get a point, that's +1. We test pinkies. If pinkies go beyond 90 degrees, we also will test the angle at the elbow when your palms are facing up, and whether or not that joint goes beyond the surface a certain amount. And so each arm gets a point, each thumb gets a point, each pinky gets a point. And then we do the same thing for knees. When you're standing and you're standing with your legs straight as can be, do those knees bend backwards more? That joint capsule comes back more than 10 degrees. And the final number is, can you touch the floor with your hands without bending your knees? And then we're really also looking at, did that come from the spine flexing and bending, which you can train, or did that pelvis and that base of the spine, the sacrum, drop? So we're looking at where that comes from as well. So those equal 9 scores. So for children under the ages of approximately 15 or so, we want that score to be less than 6. If it's 6 or more, that means you meet the criteria for joint hypermobility. Now, for a lot of people, being joint hypermobile is a completely benign situation. Maybe a party trick growing up. You have some double jointedness, you can swing your arms around and your legs. That's the extent of its impact on people's lives, and maybe just makes them better and easier at cheer and gymnastics. But within that, there's another group of hypermobility that has more things involved, other systems. So when we have athletes who are joint hypermobile, the next thing I ask about anxiety. I screen for sensitive stomachs or GI symptoms. And now with the current research, we're also starting to ask about autoimmune, things like eczema, or things like vascular flexibility, hypermobility. Are you passing out a lot, called POTS? Do you have vascular issues like Raynaud's, when your hands and feet get really hot and really cold and really hot and really cold? right? Because in the current evolving research, we are understanding how incredibly complex hypermobile syndrome can be. So for me, I jumped into this because much like you were describing before, where this is the foundation of science. If we just talk to our patients, if we just pay attention, ask a little bit more questions, have that curiosity, that's what opens up and begins to show us what is involved in an entire person, right? Not just a checkbox on a medical list, but that whole person. And as we began doing that in the field of scoliosis specific physical therapy, we were already screening for hypermobility because of biomechanics. You know, if we're doing the scoliosis exercises, you need to have a clear understanding of the biomechanics. So from that end, we were screening that. But we really started to see a very high prevalence of anxiety.
Huge.
Anxiety, depression, and it was not in proportion to apparently what was going on in their scoliosis care. Mm-hmm. And while everybody can be very variable in terms of what medical conditions makes them nervous or anxious about things, we were really starting to see a trend in this connection that did not seem to have a direct connection to the size or the risks or the functional impact or even no pain. Why were they having such high anxiety? And to be honest, in most of the scoliosis research, when you talk about research for scoliosis anxiety, they're going to blame it on factors like it's 10 times more likely in girls. It is maybe related to the sensitive developmental stage of pre-puberty and adolescence. Embracing in their peers can be really hard when you have to brace in school, and all of those things are true. But again, this prevalence in our practice was just like, this is not just solely this. So several nights I was deep into Google Scholar and PubMed. And I happened across one of the leading global teams in neuropsychiatry in Barcelona, Spain, that caught my eye. And it was about the genetic relationship and correlation between joint hypermobility and anxiety. That relationship is so well established in the world of neurological psychiatry, which I had never heard of in the orthopedic world before. I had never heard of this. I was dumbfounded that it has been validated across ages, children, adolescents, adults. It's so valid of a connection. It's cross species. There's a study where dogs that are joint hypermobile have more anxiety.
Really?
I was just flabbergasted. I'm like, how did we not know this? Like,
right?
Does the rest of orthopedics know this? Because I had never heard of it.
I can tell you, probably not.
Some of my colleagues, and I can promise you, any of my colleagues in Scoliosis Research Society, both physical therapists, orthotists, and surgeons, they're probably done listening to me. And if they see me walking down the hall, they're like, "Here comes Marissa. She's going to talk about joint hypermobility." I'm sure.
But it's good.
An advocate for it.
Yes,
it has to be screened.
We need advocates. We need advocates out there. We need to bring awareness, but not just awareness, accurate awareness. So,
Correct.
We live in the world of TikTok right now. And so many things get out there, not just TikTok, but all social media. And I will tell you, as having teenage daughters, the trends, they make themselves known very quickly, and then everybody's talking about them. And so this is another thing. So let's now talk Ehlers-Danlos syndrome, because that happens to be a little bit of a trend that's out there, along with the POTS and Chiari malformation, other things that we are seeing kind of that are interrelated. It's making its way to kids, but not all of the accurate information is in there. So now let's talk about the difference between hypermobility and Ehlers-Danlos.
Okay. So based on that 2017 international consortium, where global leaders in this area met to really do a better job of kind of laying out the terminology. And so when you're doing Google searches and parents are on that, you can still get quite a mix of it. So let's be clear. First, joint hypermobility is just that. It is the joints themselves. It is one of a part of investigating other conditions. It's one of a part of what is labeled as a whole as connective tissue disorders, right? Ehlers-Danlos is one of the leading examples of that. Marfan syndrome is another one. And for those two specific, as well as I believe now we've got two or three more others, there's approximately 26 categories, but we really only have genetic specific testing for those two. So the remaining categories don't have a clear genetic test for it. So it's more about a skilled medical provider being able to kind of put the pieces of the puzzle together and differential diagnosis, right? Where you're clearing, we know it's not other things, and we have this range of systems and symptoms that are involved for this particular patient, and they're starting to put those into syndrome kind of categories. Again, it is a default because we don't have clear genetic testing for everything, but even that is rapidly changing. So think of the connective tissue as part of the musculoskeletal, but interestingly enough, so is scoliosis and kyphosis, right? When you think about something that is genetically not growing typically, that is also one of the categories. You can have kyphoscoliotic connective tissue syndrome, right? So we know there's this shared genetic relationship there. We know we can have vascular, where maybe the veins and the arteries are more impacted. And so, for example, like cardiac conditions needs to be cleared in people that are diagnosed with Marfan's and Ehlers-Danlos. It can affect their vision in their eyes. It can affect, there's a higher risk of things going on in terms of their brain and spinal cord. Now, while Chiari malformation is rare, it's simply one of those things that is so complex that if people aren't paying attention to the details and understand that it's something that should be considered when we're looking at these people and kids that are joint hypermobile, there's a risk of that. So let's ask about those 5 things. When that's not being done, we're missing these patients. And it could not have been any more exciting and impassioned for me to have Dr. Antonio Bobeno, who is one of the world leading neuropsychiatrists on joint hypermobility and the anxiety world, for him to have come as a guest lecturer for Scoliosis Research Society in Barcelona in 2024, because it's driving this interdiscipline discussion. We need to have an understanding that anxiety was not all based on a curve or wearing a brace or girls are more sensitive. It really potentially has some important underlying shared genetics. And that's not just for non-operative. People with joint hypermobility syndrome need to have an entire pre-surgical understanding. It's so much more complex, and it becomes so much more important for us to be that bridge. Remember in that first video, we were talking about helping our parents and our patients and our coaches to bridge to the healthcare community when they are struggling with multiple systems. And sometimes you go to get a spine involved and they have no idea why you're asking about their stomach, or you're asking about, do you pass out? And it becomes so important for us to be able to provide that early screening and that early discussion and help bridge healthcare for these patients.
Yeah, and also very important to understand that a lot of times when people or especially kids, when they're thinking hypermobility, they want to sometimes jump immediately to the Ehlers-Danlos. There are some very specific criteria to
Correct.
meet that. And some of the criteria are things that you can just look at and see, things you may not think about. It is parent history as well. So that goes into it. Do you have a family member who has it? Do you have the papules on your heels? So it's things like that I think a lot of times that little step gets missed, is they go from here and they jump. So there is very specific criteria to kind of lead you into thinking that it could be the Ehlers-Danlos and not just hypermobility.
And this is a growing problem because there is clear medical criteria across all the varying types of categories that are beginning to emerge to better help serve our patients. And unfortunately, at the speed of Instagram and TikTok, where you've got people that are like, I have this and I have that. And well, the next person may not have that. That's what makes these particular conditions so difficult and challenging. Yeah. The current research is stating like it can go undiagnosed for 20 years. When you've been struggling with these various systems, whether it be anxiety, they're now seeing an increased prevalence in ADHD within this, right? So there's more and more research that is showing we've got something going on. And the autoimmune, right? That's a new area of research where we're starting to take a look at that. And we see growing trends in prevalence in that. Older medical history in this, for example, Elvis Presley had Ehlers-Danlos, but it used to be in medical textbooks that like it was so rare, like 1 in 10,000, that you could practice for your entire career and never come across somebody. But there are some specialists in the industry right now who have begun to understand and participate in the global research. Mayo Clinic, Medical University of South Carolina here in Charleston has one of the world leading tissue banks for genetics in this. And the team and their published research, some of them in the globe are starting to talk about a prevalence as high as 1 in 500 because of the autoimmune components to this, where it's just one person might be genetically predisposed to have their neurotransmitters and their anxiety higher, but their stomach's not that bad and they're a little bit flexible, or maybe they're not fully 9 out of 9 on a bait, and maybe they only have a little bit of joint hypermobility, but their stomach is really sensitive, full-blown IBS diagnosis, trying to manage that and never thinking that it has anything to do with their spine and their scoliosis. But we're starting to investigate more. And again, just being a part of that education, knowledge, and skilled practitioners who can step into that space for parents and patients and help bridge accurate information. I think there's nothing more important in helping that, because it should never be, in today's modern time, in my opinion, and I'm older as a grandmother, so to me, I'm appalled at the idea that, I can text and call and we have all this modern technology, and yet it's still taking something like 15 years to go from podium research presentation to actual practice. To me, the faster, the better, the more accurate we can get our information out, and helping parents to really individualize their understanding about themselves and or their children and what it might mean, moving forward, as well as professional education. Needless to say, I'm rambling again because this is my.
Okay, I'm pulling this over. I did not not think about the sun situation going on at my house here. So let me just get this situated here. Okay, so let's bring this back around to cheer, gymnastics, and
Yes.
dance. And the whole reason why we are having this conversation is because we have a very high incidence of hypermobility that is seen within these athletes. Okay, and because of that, we tend to have some secondary issues that occur with that. So we kind of hit on here. Let me get my ducks in a row. Okay, so we've identified the hypermobility, but sometimes when we have the hypermobile athletes, sometimes they can present as a little bit of a puzzle, especially to coaches, sometimes to their parents, sometimes to themselves. I think a lot of athletes do not actually understand their hypermobility and what that means.
Right.
And so, for instance, sometimes we can have a hypermobile athlete that actually has decreased range when they are trying to move through. And some of that will play back to motor control and
Correct.
stability. Yes. So
Right.
can you hit on that a little bit on what we're seeing in these athletes from a motor control joint stability
Sure.
perspective?
So again, it comes back to kind of geometry, physics. The laws of physics do not cease to exist inside of a sport or an athlete, right? So we can talk about certain, like if one particular joint goes too far back, then the next joint below or above it is going to have to pick up the demand of the physics, either physics in space and gravity, against gravity, but also the physics of the demand of that sport, right? So when we talk about hypermobility, if one joint is really coming back further than it should, obviously the joints above and below it are going to have to compensate. And sometimes they can be tighter, both because the position is different, as well as the muscle that controls and stabilizes the compensation is so overtrained and overused, right?
Mm-hmm.
Those of us who sit for a long time, what a complete change in my hip flexors when I stopped treating, direct patients and I was doing more research and teaching and sitting. My hip flexors in the front got so tight because I was clocking 5, 6, 8, 10 hours sitting. Very different than my upright walking, moving, treating patient time period. So I had to intentionally change that. But then we have to talk about, again, that overlap when we have dancers, gymnasts, cheers who have hypermobility and scoliosis, because the literature actually is starting to show that one particular study I always go back to in 2022, Dr. Steinberg took a look at 132 dancers between the ages of 12 and 14. And 41% of them approximately had joint hypermobility. 29% of them had scoliosis, and 26%, so more than 1 in 4, had both. And because of that, almost 74% of the ones that had both had significant patellofemoral pain and injury issues. And right, we're starting to put together the pieces in the medical research. We already know that our dancers and our gymnasts with scoliosis, because of the asymmetry in the physics, we know that they don't have the same pressure running through their feet between left and right and front and back, right? The physics becomes different because the structure is different. So it's not just about what their muscles are training, it's just geometry and physics. And so because of that asymmetry, they're at higher risks of injuries. So now you put a second piece of that puzzle on top of it, hypermobility, and now you really have a recipe for increased risks of injury and pain impacting that. When you add hypermobile syndrome on top of that, you throw heightened anxiety, sensitive stomachs, pain perception and proprioception is different in our kiddos. Now you have a recipe for a dancer and a gymnast or a cheer who might be really starting to struggle and impact their ability to participate in a sport they love.
Absolutely. And when we are looking at this from preventative standpoints, you touched on it beautifully, is that very few programs I feel incorporate proprioceptive training.
Right.
Ocular motor
Yes.
training is huge, huge, and it is like overlooked, like
Yes.
not non-existent in some cases. And
Correct.
this is CheerX performance program. Here we go. And this one is not rocket science either. It is easy to incorporate into a training program. You just have to know to, number one, do it and its implications, what doing it actually means, what the end goal is. And yep.
Correct.
Very
I mean, the
important.
vision is the most dominant system in motion like that. And we already know that patients with scoliosis have do not have an accurate proprioception. I was going to
Correct.
say it was
Yeah.
unbalanced, right? We already know that in the research, right?
Yeah.
They don't have an accurate sense, right? Any family with scoliosis, if you take a look at the pictures and they're like, geez, it's because that is what they feel is their middle or their center, but it's not accurate in space.
Right.
So just because they feel comfortable over here or they prefer over here, their resting posture brain center has them here. It's not the reality of the geometry and the physics. And that's where it becomes so important. And most people don't know you can train that. You can retrain that. You can
Very
impact
easily.
vision, proprioception, and you can retrain that. The famous thing from our conversation in the first video where we were talking about how I had a habit of standing in first position with my feet turned out. And after years of teaching Schroff, just because for no other reason than I'm demonstrating to my patients where we begin with our feet, like parallel, like the number 11. 5 years later, my girlfriend, not related at all in the field, happened to have been like, what happened to your feet? Like every time we were standing at Starbucks or in the grocery store, your feet always turned out like a duck. You're standing straight. Like, what happened to your feet? And I looked down and I was like, oh, well, apparently I've re-educated myself.
Yes, you motor learned.
You are learning. So it's
That's right.
possible. And for some that are struggling with it, if in fact we're assessing them accurately and we see some of their pain or dysfunction is connected to these biomechanical issues, we really need to have the accurate treatment assigned to this. And this is where I think general orthopedic physical therapy or athletic trainers can miss. Same thing with regular yoga and Pilates. These are all wonderful things for regular, typical spines and biomechanics. It is not necessarily going to accurately address any symptoms or pains or impairments if you've got some of these medical conditions that are underlying. So it really becomes important to have someone on your team that has that level of medical knowledge.
Agreed, 100%. So we kind of hit on this. So when we're talking training strategies to put in, we don't want to think the general exercise. We do not want to go that route, although general exercise is not bad. Okay. We don't want to say that it's bad. General strengthening is good, but some of these hypermobile athletes, their bodies do not respond the same way that sometimes someone who does not have hypermobility. And again, it goes back to number one, awareness. We have to be training their body where it needs to be in the first place, not where it has evolved to. Okay, so that's number one. Number two, we have to teach it stability, and that is not always in the form of a strengthening exercise. Sometimes stability comes from that proprioceptive training and motor learning a new skill. You said it earlier when we were talking about dosage in our previous webinar. I mean, think of the dosage that we're going through, that these kiddos are going through in their training. And they're doing that for hours and hours per week.
Right.
but we're not counterbalancing those activities with things that will keep their posture where we want it, that will train their joints to be
Right.
where we want it. So that is really what we want to drive home as far as the athlete is concerned, is there are things that you can do to train these things. So proprioception is one, oculomotor is one. Uh, Also training in smaller ranges. So here's a
Absolutely.
concept. Yeah. So a lot of times I feel like there is such pressure. And really my dancer is who is in my head right now when I'm going through this. But I feel like there is so much pressure for achievement when they are in class, and they want to get those big, beautiful, long lines going, and they don't have the motor control to go through the whole range. So I think really trying to educate on the importance of learning motor control in small range and then building upon that.
Yeah, absolutely. Again, you have to go back to not just exercise being muscle specific to the deeper stabilizing muscles and not the power muscles.
Mhm.
So you're not going to general PT
Mhm.
and doing back exercises for the big surface muscles or the hamstring and quads and things like that. You're really having to retrain the whole chain to give them that correction, because if they're hypermobile on and they're overextending here, you have to teach them to come back here, then squeeze and perform the
Mhm.
stabilizing exercise. If you squeeze and perform the stabilizing exercise back here, you're just simply
Yep.
not anatomically going to be doing it correctly.
Yep.
And it will not have the same effect, right? We know this from, again, basic science research, right? The length and tension relationship in a muscle is relevant to how well it's going to contract and work. So this is where three-dimensional corrective positions, then you squeeze and hold and gain the strength and the volume in those stabilizing muscles. It's the fundamental principles behind scoliosis specific exercise. It's the fundamental principles between hypermobility, physical therapy, where you want that
Mhm.
mid-range stabilization, but it can't just be a single joint. It has to be in that
Mhm.
full motor pattern. Even if you're an
Absolutely.
adult, you're just walking, right? If you're constantly walking and slamming back your knee into that hypermobility, it's not going to be the same thing.
Mhm.
And it is trainable. I always say I had a young girl who specialized in violin, seated violin always in this side.
Mhm.
Baton score performed. She was 8 out of 9. Hypermobile in every single joint that we tested except one, her left elbow. Now, why would the other
Ah,
one be so hypermobile? Like we didn't even need to test the range. Like you could see it walking.
uh-huh.
Like, yes, that's a point. Yes, that's a point. Yes, that's a point. Right?
Uh-huh. That's interesting.
Why? She practiced
Yep.
violin and she contracted this muscle here in
Mhm.
her bicep for hours a week.
Hours.
Hours a week. She was, and this was now a muscle that had grown tighter and overcame, and she could no longer hyperextend that elbow.
Mhm.
And it's just simply high dosage muscle joint training.
Training.
She just didn't
Yeah.
realize she was doing it with her violin.
Mhm.
And I was like, oh, tell me what your activity is, because that's really interesting that, that elbow's hypermobile and that one's not.
How one
Like,
isn't.
oh, I
That is
said,
so interesting.
I said,
I
how
love that
often?
example.
He's like, 10, 15 hours a week. I'm like, oh, bingo. There you go. Bicep tendon,
Hmm.
super
I'm
trained.
gonna I'm gonna steal that one, Marissa. That's a really good
It's a
example.
perfect example of it.
Really good example.
I was just
Yeah.
like, there it is, right? It also explains
Okay.
why the Baton score becomes less valid with age and time, because
Correct.
you
Yes,
can
that's very
have
important to
as
understand.
adults. It's really important to understand that, Baton. It's also why the score
Mhm.
is lower in if you're going to be testing adults. 6 out of 9 for kids, 5 out of 9 for adults. And even then, um, when you navigate some of this information, say, for example, on the Ehlers-Danlos Society, which is my all-time favorite resource for any of my patients or families with questions about hypermobility, professionals that are looking to investigate more about this as it may or may not apply to your patients. It's just a fantastic medical society. They will talk about how that becomes a historical question process. And there are some guided details in asking the questions of our adults from a historical perspective, like helping them to think about what they may or may not have been able to do when they were younger. Did you now, or have you ever had, right, double jointedness, things of that nature? And I find that in our clinic, that is still extraordinarily helpful for us.
Oh, very helpful. Absolutely.
Adult patients, to help them understand more about why that may not test positive as an adult, because we're sitting, we've gotten older, our muscles and our joints have gotten tighter, and so the test itself is no longer valid. But it doesn't mean genetically you're not still hypermobile syndrome.
Right. Yeah. And sometimes, and it's also important to remember that, you know, your Baton score might be negative, but or under the mark, but you can have regional hypermobility as well. And it does not have to be on the global scale. So that's just another part of it too. But let's move forward and let's talk about the connection to cheer and dance and gymnastics as far as injuries. Okay, so this is important because I feel like in this population, I feel like we have coaches and parents and athletes that they don't know what to do because they are injured all the time. And so I think number one, awareness is that if you are injured all the time, and it's not necessarily just one joint over and over again, but it is, you might have an ankle injury, a knee injury, a shoulder injury, back pain, and it's like you're chasing these injuries over and over and over.
Correct.
Go looking for some of the causes under this. So I think sometimes these are the kiddos that are labeled. They're labeled, I think they're like, are there really injuries? Because they're injured so often. But yes, there is an underlying reason for this.
Yep. There was a great study that was done in 22. Again, Dr. Wong et al. Talked about the association with scoliosis and dance injuries, and took a look at over 700 dancers. And in their 12-month history of injuries, lumbar, knee, and ankles were the three that were investigated. 24% had lumbar injuries, 22% had knee injuries, and 28.5% had ankle injuries. It is so clear. Now, granted, that particular study was a survey, and so the patients were reporting it themselves, right?
Yes.
So it's not hard connected to an actual medical diagnosis, like if we were talking about medical record review, right? But it's still such a powerful, large number. I mean, 704 dancers, right? That's 13% of them had scoliosis. And when you took a look at that, and now we have other literature that's talking about scoliosis and hypermobility when dancers and gymnasts have both, right? You cannot take away the fact that the physics and the geometry and the anatomy and physiology are presenting itself to put an increased risk of injury. And as for all competitive sports, right? A small injury, it's so easy in that characteristic and personality types to just kind of like, take it, blow it off. It's just a little twist. It's just a little twinge. It's a little what, and, the pain goes away and you're back out and you're 90 miles an hour again. But when you start to see a history of them, like you said, it really becomes important for us as the adults, the coaches, the trainers, the therapists, the physicians, to really have a better understanding of the overlap in these worlds, so that we're safeguarding those of our kids that live in these sports with scoliosis, or scoliosis and hypermobility, or just hypermobility. We have to be able to
100%. 100% agree. And, and so just also touching on, and that I think that's why it's so important that we're distinguishing between flexibility and hypermobility because the
Yes.
two are not the
Yeah.
same.
It's so easy
Um,
to misconstrue these things in those particular sports. Yeah.
mhm.
Well, this has been a fantastic
Yes,
conversation. Thank you so much for letting me kind of spew about one of my areas of passion and research. And I hope to be a part of continuing to have that awareness grow within the orthopedic community for those of us that treat
absolutely.
scoliosis, but also so important for early diagnosis and screening for our cheer, gymnasts, and dance
Mhm.
patients and populations
Yeah,
and parents.
I think so much it's about, yeah, we're connecting those dots,
Yeah.
trying to get the little aha moments, the little light bulb
Yep.
going off, and then
Yep.
just the tips, the tricks, and the resources to
Yeah.
be able to help.
Your kids are going to be very lucky to have you.
Aw, thank you, Marissa.
You're
Yeah, thank you for
welcome.
joining us today. Such great
My
information, and we
pleasure.
will talk soon.
Have a great day. Bye.
Bye.